Hi, I'm Lucia Gambuza with the Eye Care Network, and today I'm joined by Dr. Ellis Wisely, Associate Professor of Ophthalmology at the Duke Eye Center, where he specializes in cornea, cataract, and refractive surgery. Today, we're talking about the evolving role of cataract surgery as a refractive procedure and what that shift means for patient counseling, expectations, and outcomes. Dr. Wisely, thanks so much for joining me today.
Well, Lucia, thank you so much for having me. I appreciate being part of this program. It's exciting.
Let's jump right in. Cataract surgery has effectively become the most commonly performed refractive procedure in the US. How has that shift changed the way you personally define success for a case?
That's a great question. I think that, more important than I define success is making the patients happy. How do the patients define success? So more than like 2020 or 2030 or some objective result that I see on paper, I think that you've seen others use the term 20 happy is really what we're looking for the patient. So it means that we have a lot more work to do as cataract and refractive surgeons up front when we meet the patient to understand what exactly it is they're looking for. Because certainly you can have a patient with 20/20 distance vision who ends up unhappy, perhaps because they don't have the near vision that they're looking for. So, it's each patient, there's a individualized medicine where each patient is seeking something different, which is very common. So we need to understand what's going to make our patients 20 happy, and then we as the surgeons can be happy once we see the smile that the patients have.
To stay on that topic, when you are counseling a patient who came in because of a glare and blurry vision, not because they're unhappy with their glasses, how do you introduce the idea that this surgery could also change their dependence on correction?
I think that it's important because there are so many options for specialty lens products, premium lens products. So hear about from their friends, family, others patients in the marketplace. It's important for us to introduce the concept of these lenses to all patients. Not, I don't try to make a read of the patient when they come in and make a read of certain characteristics that they have that might make them a multifocal candidate or not, for example. I want to give a broad introduction to the what's available to all patients who are there for cataract surgery, whether they've ever heard of multifocal lenses, whether they wear glasses or not, whether they want to wear glasses after surgery or not. I think a general explanation of what can be achieved can really open the eyes, for lack of a better term, of many patients who maybe they didn't consider that they valued spectacle independence before they came in your office, and they think it's so neat that you can offer that. And at the other end of the spectrum, you may have to tell patients who come in and say, I want this trifocal IOL from the first thing they say, they may wind up not being a good candidate, and you have to explain that. So I give a general explanation of what is a monofocal, what is a toric, what is an EDOF lens, and what is a multifocal lens to all the patients. And I explain briefly that some are covered by insurance and some are not as an introduction to this topic. And sometimes patients will shut you down quickly and say, "Oh, I want to do what my insurance covered. If that's a service that's outside of insurance, we don't need to talk about it anymore." So it can be, it doesn't have to blow up your flow in your office. It can be something that can work if introduced in the right way for all patients, can work for your chair time as well, where you can give patients an introduction and give them an opportunity to sort of jump off of the premium IOL conversation if that's what they desire to do.
And where do you draw the line on which patients you do actively pitch on premium options versus let self-select?
Yeah, my objective is to let everyone self-select. I try to again lay out here's what exists. In the first question, I'll often say to patients who are kind of on the fence about what they want to do with a premium IOL versus a monofocal or standard IOL, for example. I'll often introduce a question that help differentiate, which is that the question of do you value independence from your spectacles in such a way that you'd want to pay out of pocket outside of insurance for it. Because if they say glasses are great, I'm great with bifocals, which patients say that in my office every day, then you say, okay, great. Well, we don't need to go into more detail about, excuse me for those beeps, we don't need to go into more detail about the specialty lenses. You can say that, okay, great, those are out there, but we'll plan for the insurance covered option for you. So I think that, again, a sense of do they value spectacle independence at all is a good early question to get a sense of how deep you need to dig on those on the specifics, nitty gritty of trifocal versus EDOF, for example. A lot of times you can leave that out if patients, make it clear that they like wearing glasses, for example.
Right, absolutely. That makes a lot of sense. What's the hardest conversation you have with a patient who might have unrealistic expectations about spectacle independence going into surgery? And how has your language around that evolved over your career?
The hardest conversations, which I do everything I can to avoid, are conversations that occur after the surgery, right? So, conversations like, hey, I'm reading the chart when I'm 20 feet away, but when I hold my iPhone up here, I can't see anything, And sometimes we as surgeons, and we trained in an era where the standard was monofocal, and that was sort of didn't used to be such a detailed conversation, sort of like you're bringing up when there were fewer options. So 2020 distance results great, and it's an assumption that patients are fine with reading glasses, which that's certainly not a safe assumption in any consultation. That you need to help patients understand that a great result with the monofocal means that everything from your arm's length in is blurry without glasses. So those even in patients who aren't premium patients, maybe they wanted to be and they didn't know that they wanted to be. I think that's maybe the hardest one that I see occasionally. I try to head that off again with the preoperative counseling, but occasionally you have somebody who says, you told me that I was going to be blurry from my arm's length in, but I didn't understand what that meant. And the patients who you have to be particularly careful with are your low myopes who don't really understand what presbyopia is, right? They've spent their whole life take their glasses off to read, and they don't understand that after cataract surgery with the distance target, that's going to go away. They are making a trade of their near vision for distance vision, so that has to be very clear with those patients. And I do a good job of being explicit with that, but occasionally you have patients who, after the surgery, they get something different than what they expected. So those are the toughest patients where you're telling, well, if you want to change it, you got to go back to the OR again and pick a different lens. Those are the trickiest.
Absolutely. And you've led perfectly into my next question about informed consent for cataract surgery. It's now often includes discussion of that near, intermediate, and distant vision trade-offs. Territory that used to belong to refractive surgery consults. Has that changed how you or your staff structure that consent conversation that happens prior?
Oh, definitely. Yeah. Yeah. Like I mentioned, I, with all patients, try to make sure they have an understanding that in general, we talk about three ranges of vision. We talk about distance, and we talk about intermediate, and we talk about near as three separate things. And I try to introduce examples into that conversation, both in the exam lane and in their daily life. So I talk about, distance visions for driving or for television, and intermediate visions for something like a computer. And I demonstrate with my arm where that is, because laptop, computer, tablet, those are different than if you have a bigger screen. So, and I talk about near vision targets like reading a novel. So I give examples in the exam lane and in real life of what we're talking about with distance, intermediate, and near vision to establish that we're using the same terms of what we're trying to provide for the patient. And then talk about how the lenses, in broad strokes at least, EDOF, multifocal, and monofocal fit into those categories of options. So I think it takes a little bit of background education. It takes a little bit of chair time, and I think you have to, more than anything, a takeaway from this discussion would be that I hope that my colleagues will commit to spending a lot of time up front, because when I get patients who come from other surgeons for a second opinion after they've had cataract surgery and they're unhappy, the most common reason that I can point to is not that the surgeon didn't execute their surgery well. Typically, the surgery looks great. But more common than that is that the patient didn't understand before the surgery what they were going to get afterwards, and the surgeon would say, "Yeah, this is what we expected," but the patient wasn't on that page. So just there's no replacement for good preoperative counseling and taking your time with your pre-op patients.
Definitely. And setting those expectations ahead of time is very important. Moving over to the IOL side, how has the availability of newer IOL technology changed what you feel obligated to offer or at least disclose to patients versus what you actively recommend?
Yeah, it's definitely changing our discussion about glare, halos, dysphotopsias. I think with the newer technology of IOLs, those type of postoperative outcomes are becoming less and less common. So, it used to be that patients with any sort of ocular pathology, for example, um, just very mild Fuchs dystrophy, let's put that out there. Perhaps you would say you're not a candidate for specialty lens product because of this other condition that you have on in your eye health. But now with EDOFs, for example, being much more forgiving with some degree of irregularity in the cornea, um, those options have become available to patients in that type of situation. And some of the newer multifocals, I think that still jury's out to some degree, but may be appropriate for patients with mild other ocular conditions, conditions like glaucoma or early macular degeneration. We have to see with specific lenses, each one kind of has to be evaluated separately. But I think that in general, we're seeing lenses that are more forgiving with less risk of glare, halos, dysphotopsias, and kind of opening up the door to patients with mild other ocular pathology that can now become candidates. So it certainly makes the job of the refractive cataract surgeon harder because you have to consider the severity of those other conditions. You have to consider which type of lens you're talking about. And you can't just, I don't think it's appropriate at this stage, though, to just put out a blanket statement. Any kind of other eye problem, you can't do these lenses because there are many patients who, with mild other ocular conditions, who can be very happy with specialty lens products and the new scene of IOLs.
And my last question, for a patient who's borderline early cataract, still functional vision, but curious about premium lens options, how do you counsel them on timing surgery, given that when it is medically necessary and when do you want it are now two separate questions?
Yeah, that's a great question. I think you have to have a clear distinction for yourself as a surgeon, and certainly you have to do this for your billing purposes as well. You have to have a clear distinction of what is a visually significant cataract, of course, and that has to determine one, if it's visually significant, can you do cataract surgery? Are you talking about a clear lens exchange, which of course is a very similar procedure, but billed in a different way. And so you have to have clear guidelines in terms of vision testing, glare testing, best corrected vision, visual acuity, appearance of the cataracts qualitatively, and the patient's symptoms and their effects on their activities of daily living. You have to have those clear in your mind and document them clearly for yourself and the patient to determine what exactly you're doing first off. So you have to establish that these cataracts are affecting the patient's activities of daily living is the key thing. And then, are you talking about cataract surgery or clear lens exchange is one thing, but a little bit different from that is, okay, you're talking about a cataract. It's visually significant, but it's pretty mild, right? It's having a mild effect on their activities of daily living. That's a different and a little bit actually more tricky conversation is to say, hey, it's there, it's affecting your vision, but when's the right time for surgery, which I think is more the question which you're asking. And I think that depends again on what the patient's goals are. If the patient has a visually significant cataract, but they're eager to achieve spectacle independence, then I think you move forward as soon as you can put it on the calendar, as soon as the patient wants. One thing that's sort of a general guideline that I consider as well is what is their current spectacle status? Are they hyperope or myope? So currently, do they wear glasses for everything, some things, or very few things? So certainly you don't want to be in a position where you do a surgery and you offer them sort of they do it and they're in a similar position to what they were before with their spectacles when they were seeking to reduce them. But now they needed reading glasses before, now they still read them after, or situations like that. You want to at least give them something that they didn't have before, and your hyperopes are much easier to please in that paradigm.
All right. Thank you again, Dr. Wisely, for sharing your insights on cataract surgery's evolution as a refractive procedure. For more coverage of the latest in ophthalmology, be sure to visit ophthalmologytimes.com. I'm Lucia Gambuza with the Eye Care Network. Thanks for watching.